Ashley Huppe.
And my name is Marc Inciardi.
We are breast imagers at the University of Kansas Health System. We want to give our audience a preview of our paper on automated breast ultrasound that is to be published in Radiographics. Dr. Inciardi, why don't you start off by talking about our experience in using automated breast ultrasound and the genesis of this paper?
Sure. Our experience goes back to 2009 when we were part of a nationwide trial called the Huppe and Inciardi trial, which evaluated the use of automated breast ultrasound screening as a supplementary screening modality in patients undergoing mammography. That study, which was published in Radiology, involved over 17,000 patients, which is still the largest study of automated breast ultrasound to date. The results showed an increase in the cancer detection rate of almost 2 cancers per thousand over that of screening mammography. But one of the critiques of the study was that of a callback rate of automated breast ultrasound was high. And there were several reasons for that. The transducer used at that time was a first generation design with a flat head, which resulted in poor compression on the edges of the breast and artifacts from Cooper's ligaments. Also, both technologists and radiologists had less than robust training in scanning and interpretation. Lastly, most radiologists were not familiar with the nuances of ultrasound screening, resulting in a high callback rate. Since that time, there's been the introduction of both second and third generation transducers with curved head design, which results in better side-to-side compression and improved resolution. There's also a robust training program. Our callback rate is in the 5 to 7% range, which we believe is reasonable. We've had the opportunity to train hundreds of radiologists on automated breast ultrasound over the years, but in talking to radiologists, we continue to get questions on how to improve callback rates. A few years ago, I gave a presentation at RSNA on how to reduce callback rate, and it was well received. So we decided to pull all our thoughts on paper and submit it for publication. Dr. Huppe, can you describe for our listeners some of the pearls, tips, and tricks they might learn from reading our paper?
Sure. Our paper is divided into two parts. We first compare and contrast handheld screening ultrasound and automated breast ultrasound, highlighting the strengths and weaknesses of both modalities. We describe in depth the cancer detection rate and callback rate of each modality, as well as scanning time, interpretation time, what a standard examination should include, and FDA-required training. In the second part, we move on to describe a number of pearls and pitfalls of automated breast ultrasound, which can help readers improve both sensitivity and specificity. One of the pearls that we highlight includes how to establish confidence in automated breast ultrasound early on by performing a limited scan on all patients undergoing ultrasound-guided biopsy the same day. After reviewing a cohort of over 8,900 patients at our institution, we found that the vast majority of cancers can be confirmed on 2 datasets, if not located in the periphery of the breast. Therefore, confirming suspicious findings in more than one plane can be very helpful. The coronal plane, which is unique to automated breast ultrasound, can be unfamiliar to some radiologists. As the vast majority of cancers can be visualized in the coronal plane, learning how to recognize cancers can improve performance. Likewise, as automated breast ultrasound is a volumetric acquisition, there is a software rotation tool which is available that, if used, can improve accuracy. One concept that we try to convey is that cancers on automated breast ultrasound look like cancers on handheld ultrasound, which we are all used to. In screening, radiologists should focus on letting go of questionable findings which are unlikely to represent real pathology. I know that one slide you used when teaching this concept, Dr. Inciardi, is that of picking the low-hanging fruit. We try not to call back lesions which have typical features of fibroadenomas. In our combined cohort of 3 practices representing nearly 90 cancers, we have yet to find a cancer that has typical features of a fibroadenoma. When performing callback diagnostic ultrasound, we find it really helpful to carefully review the original automated breast ultrasound to ensure that the area of interest is fully evaluated. Correlation with the automated ultrasound finding and handheld ultrasound finding can help reduce future callbacks as well. Is there anything you'd like to add, Dr. Inciardi?
No, I think you've covered the high points. We hope that those reading this paper, whether just beginning to screen with automated breast ultrasound or even more advanced readers, are able to benefit from this presentation. Thank you.
Thank you.